Okay, good afternoon, ladies and gentlemen. Thank you very much for great invitation, Mehdi. My topic is a wire choice and approach to close tibial artery. I have nothing to disclose. Generally, compressed BTK lesions frequently found in the clinical setting. In our OLIVE registry, 64% of lesions were chronic total occlusion, or 75% of lesions longer than 15 centimeter lesion length in BTK real-world setting. For treating the chronic total occlusion, there are 3 steps in achieving the successful revascularization. The first step is how to successfully close the lesion. There are several tips and tricks for wire closing. I think the standard BTK technique is a safari technique which has introduced as a subintimal arterial flossing with antegrade retrograde intervention. To achieve the successful wire closing, how to establish the bidirectional two-way approach is a key procedure tip and tricks. During the initial angiography, calcification severity, access site for retrograde approach, and good collateral for retrograde approach should be precisely evaluated. Here my preference wire in BTK revascularization. My first choice is a regalia. If CTO has a microchannel, Gladius, which has a 3-gram tip load with press shape, is also useful. So this is a represented case treated with a Gladius 3-gram wire. Bilateral calcification helps us closing the right way as a guidance post under use of Gladius 3-gram wire, which have a press shape and good trackability. Because CTO had a microchannel, Gladius wire was gently advanced and successfully closed without any additional retrograde approach. After wire closing, angioplasty with 2 to 2.5 mm for distal BTK and BTA, and 4 mm for 4 BTK were done. So here is a final angiogram. Left posterior tibial artery and the lateral plantar artery were successfully restored. So what is the most reliable revascularization technique in complete occlusion in BTK era is a step-by-step using the knuckle wire technique. In our experience, 035 knuckle wire is mostly fit for BTK-CTO, while 14 knuckle wire technique is reasonable for BTA-CTO. After almost reaching the pedal artery or distal artery, 014 3-gram Gladius wire would be appropriate to get the distal true lumen. So here's a representative case treated with a knuckle wire technique. Target lesion was antertibial artery long CTO with severe calcification. 5 French long Cs was placed at the popliteal artery, and 014 regalia wire was firstly used for wire closing. Unfortunately, due to the severe bilateral calcification in CTO site, 014 wire was not advanced to the region. We therefore switched from the 014 system to 035 system. Knuckle wire technique using the Terumo 035 J-tip wire accompanied with a CXI 4 French caster was applied to close the lesion. After 035 wire was just staying above the true lumen, dorsal pedis artery was punctured under duplex ultrasound. 014 knuckle wire was again done, and we confirmed the antegrade wire touched the wire from dorsal pedis artery. Finally, a wire rendezvous wide regalia wire was successfully achieved. After wire closing, angioplasty with 1.5 to 2 mm for distal BTK and BTA, and 2.5 to 3 mm for 4 BTK were done. Left anterotibial artery and the dorsal pedis artery were successfully restored. So here is also represented hemodialysis case, mainly treated with the 035 knuckle wire technique. Infective wound was located at the dorsal side, and the target region should be anterotibial artery based on angiosome concept. This case was the most challenging case in my experience because extremely severe calcification was found in long total CTO. In this case, because we could find the microchannel in the anterotibial artery CTO site, ipsilateral common femoral artery was punctured and the interluminal approach was initially conducted. However, microcaster could not pass through the CTO site. This is a sign for being hard to recanalize interluminary. We subsequently switched to the subintimal approach using the 035 wire technique. Despite the tiny vessel with bilateral calcified region, 0.35-inch large focus wire accompanied with the CXI caster was smoothly advanced in the subintimal space. Next, we switched to the retrograde approach. Dorsal patelis artery was additionally punctured under fluoroscopy, and 4 French sheaths was placed because more strong backup force was needed for wire crossing. Knuckle wire technique using 0.35-inch thermostiff wire was also used with retrograde fashion. Finally, antegrade wire was almost reached to distal true lumen, and the wire rendezvous was succeeded in the CTO site. After successful wire rendezvous procedure, 3mm balloon caster was used to dilate the 4 region. The occlusive region with severe calcification in anterior tibial artery was successfully revascularized from the origin to pedal artery. So in every case, after successful wire crossing, appropriate cyborg balloon should be selected. I have one simple question for audience in this case. Which balloon size are you going to select in this case? If I check the vessel diameter by QVA, distal ATA was 2 mm, which is an indication for 2 mm or 2.5 mm balloon use. However, if IVUS conduct for assessing distal vessel diameter checking, diameter is 3 mm by 3.5 mm, which is indicated for 3 mm balloon caster. How about the proximal anterior tibial artery? QVA showed a 3.8 mm, but IVUS reveals that much larger vessel diameter was found here. Finally, 3 mm balloon angioplasty for dorsal patelis artery and a 4.5 mm balloon angioplasty for proximal ATA were done under IVUS evaluation. So here is a completion angiogram. Angioplasty and a 3L strategy, larger balloon selection, low pressure, and the long inflation lead to optimal result. So this slide shows a summary of the current BTK DCB trial. If you take a look at the reference vessel diameter, we have a big difference regarding the reference vessel diameter among the study. I think that the larger DCB size selection which lead to better outcome. Anyway, the BTK and BTA diameter are commonly larger than you expect. In summary, bidirectional two-way approach, knuckle wire technique, for a knuckle wire technique using 0.35 for BTK, 0.14 for BTA, and IVUS evaluation play an important role for achieving the optimal result in the complex infrapop-CTO CTO. Thank you for your kind attention.
Thank you. Thank you so much, Dr. Iida. That was an impressive presentation of cases.